Well, thank you for joining us today for the final webinar in our Talking Health series, Telehealth Tomorrow, Beyond the COVID Crisis. I'm Sean Mcmill, Executive Director of First Step House and 2020-2021 Chair of the University of Utah College of Social Work's Community Advisory Board. Back in April, at a virtual board meeting, my board colleagues and I shared our experiences of being catapulted into telehealth to serve our clients during this pandemic. We knew we were not alone in this venture. We knew we were learning fast, discovering some powerful opportunities and facing new challenges. We also had a lot to learn. Board members, supported by the College of Social Work Dean Martell Teasley, Professor Brad Lindahl, and others in the college initiated the Talking Telehealth webinar series to invite discussion about these past experiences and future plans. Therapy options have changed dramatically and quickly since mid-March, and many of these changes reflect the new normal that will exist when the pandemic passes. Our panel today will address the changes that could be here to stay and the exciting opportunities that have emerged. As with the previous two webinars in this series, we want today's events to be a conversation around these issues. As talented as they are, we acknowledge the men on today's panel represent a limited perspective from our diverse community. Neither they nor we mean to suggest that this group holds the key to the future of telehealth care. We strongly encourage you, our equally talented and richly diverse colleagues, to share your experiences and ask questions so that we can have another engaging and inclusive online exchange. This is one chance to explore the future together. We hope there will be more. We welcome back moderator Tamara Atala, a fellow College of Social Work Community Advisory Board member and Director of Pediatric Behavioral Health at Intermountain Healthcare's Primary Children's Hospital. He will introduce you to and facilitate the online discussion. Tamara.
Hey, thank you, Sean. Appreciate it. And I'm really excited about this opportunity, and I'm excited about the interest as we've all sort of jumped into this work in incredibly quick fashion. And so, again, I wanted to reiterate Sean's points about this. Our experience has really been built off of the sharing of ideas and the dialogue. And so I really want to encourage everybody to share that information. We ask that you do that within either the Q&A or the chat section, and we and our colleagues will monitor that and try to direct those questions. And so the intent of this has been to be very organic, and our desire is just to have this conversation and learn from each other's experiences and learn what's been valuable and what have been challenges and what would be very exciting to consider in the future post-COVID. So with that in mind, I will start this off by bringing us to Cliff. If you could introduce yourself and share some perspectives.
Yeah. Well, my name is Cliff Aukerman, and I am one of the newest members to the Community Advisory Board with the College of Social Work. But I'm also clinical director at Altium Health, where we have a hybrid of services, both in person and face-to-face video. And then I also have a private practice that I've had for the last 6 or 7 years called Outpatient Behavioral Health, where I do a lot of different things, working with a lot of different diverse communities, specialize in one of those things is telehealth, televideo, since probably 2013, 2014, being one of the first teletherapists using some pretty big platforms like Breakthrough and VC. And so I'm just happy to be here. I have a really strong interest in telemental health, telebehavioral health, whatever we call it, telepsychiatry, tele anything. I've been interested for a long time. The clinic that I work at is Altium Health. It's an addictions medicine clinic. And so we do a lot of medication-assisted treatment, MAT. And one thing that I've been really interested in is what I'm calling technology-assisted treatment. So I've been interested in not just video and telehealth, but I've been interested in apps and the ways that we can use text messaging and other platforms to really engage our clients and the people that we work with. If they can't, or don't prefer the traditional in-office face-to-face kind of stuff. So I'm happy to be here and be on this panel with the rest of you. So thanks, Tamer.
Thank you, Cliff. Appreciate that. I think it's exciting to kind of think about an organization that's been doing telemedicine well before COVID. And so to kind of listen to Cliff's perspective about thinking even beyond that classic kind of session via video and what have you. So thank you, Cliff.
Yeah.
Dr. Scott Whittle.
Yeah, I'm Scott Whittle, Medical Director at Select Health. I have training in child psychiatry, adolescent psychiatry, adult psychiatry. I think the perspective I might try to bring to the conversation is because of my role as Medical Director at Select Health, how does a payer support the process of care improvement with an eye on quality? I think an eye on value. We have as a payer, we have a unique perspective on value because our perspective is always population-based. Our effort is to try and distribute a benefit out to a population to try and, it's right in our mission statement, the healthiest life possible, which includes a lot of tough decision-making about what to support, in what form to support it. I'll also add, because this comes up in pretty much every time I enter a panel or a forum, is a lot of what a payer does is handed to us by stakeholders that are outside of our own organization. Those stakeholders are numerous, but include CMS in the form of Medicare, Medicaid. We have state stakeholders that take the form of Medicaid especially. CHIP and these products, they all have their own benefit structure design, and they all have their own objectives. And so although our objective is to, as Select Health, our objective is to try and administer a healthcare plan to try and improve the wellness of a community, it all happens within a context and opens up discussions on how to engage our partners across the board and try and accomplish that mission to the best of our ability. But very happy to be on the panel today. Thank you.
Great. Thank you, Dr. Whittle. Yeah, I think having the perspective of a payer, I think, is really, really interesting in terms of the learning that's been happening, and as multiple panels and providers that are affiliated with Select Health in terms of them working through their experiences, perhaps really, really strong, perhaps indifferent, and sometimes even a little bit detrimental at times, depending on the circumstances. So I appreciate your perspective there. Given Dr. Whittle's comments about CMS and sort of some of the framework, I thought it may be appropriate to bring Pete into the conversation.
Thanks. Hi, everyone. My name is Pete Caldwell. I am a program administrator with the Division of Substance Abuse and Mental Health. One of the programs I oversee is the telehealth program that we have as a part of the Department of Human Services. Some of you may know about it. We have a contract with a telehealth software provider called InTouch. And what we've been trying to do is to spread that system, or to spread the good message of telehealth statewide to our providers, which are primarily the local mental health authorities and the local substance abuse authorities. So a lot of what we've been trying to do is to help these authorities set policy, help them engage their clients, and kind of help troubleshoot along the way, and complete all of that on a HIPAA and 42 CFR compliant platform.
Thank you, Pete. Appreciate that. And as we're going through, the intent here is, as you have thoughts or questions, we will absolutely get through everyone in terms of their introduction. But if you have thoughts or questions, please feel free to that chat or Q&A section, and we'll absolutely try to get to those questions. With that in mind, Kevin.
Yeah, sure. I'm Kevin Curtis. I'm an LCSW, and I serve as the Director of Hospital Crisis Services for University of Utah Health and the Neuropsychiatric Institute. I come at this from the perspective of somebody whose major work responsibility is access and creating access and promoting access. And as somebody that personally has really kind of struggled to find that balance between the direct access needs of our direct community versus expanding access to our rural communities, to the Intermountain West, and to these places that are in need of support don't have the resources. And doing all of that within the context of systems that don't necessarily have a good understanding of the role that telehealth plays in the access mission. And so I've been really, I mean, I won't go so far as to say I'm very pleased that we are in the midst of the COVID pandemic, but I think that it's fair to say that this has been a really great opportunity to overcome some institutional barriers to really moving forcefully into this space, you know, in a way that was able to create some pretty quick proof of concept that some of this stuff really does work, and some of the buts that have kept people from really moving into this space were not entirely legitimate kind of concerns, but more just institutional barriers. So
I appreciate that, Kevin. I'm wondering, just as a quick follow-up, as I'm listening to you, is particularly in the work that you're doing with regards to access and crisis, are you seeing any opportunities specifically that have been loosened as a result of COVID? I mean, again, that's what sort of precipitated a lot of this engagement, where we went from almost entirely an in-person response to entirely virtual treatment, given that Uni, of course, has their Safe UT app, and I don't know if there's been other things during COVID that you would like to see either continue or see some real opportunities, as you indicated, based on some of the proof of concept that was sort of forced upon us.
Yeah. So kind of going back to the idea of the opportunity, I think what happened, or what is in the midst of happening really, is we've been thrown into the space where out of necessity we've had to completely reinvent paradigms of treatment. We have our clinicians that know the work that they do, but it's forced kind of an immediate culture shift around how do we provide care, and there are lots of assumptions that have historically been made around what is the value of being in person versus what are the things you lose when you're doing this over telehealth, and those are not invalid things to be concerned about. We know that there are pros and cons to both of these things, but I think kind of what happened was we quickly have found that those concerns, while they remain valid, they're not valid to the point where it makes our interventions not useful or not effective. And so, like, I think that culture shift is here to stay. We've learned that this really can work. We've learned that maybe it's not the solution to every situation, and there will always be kind of the need for in-person services, but there are, I believe, several target areas where because we have this proof of concept, because we know this works, because we've been forced to test the infrastructure of it and get confident with the technology, because we've had to really quickly learn these skill sets for how do I translate what I've always done into something that's a little bit different and make that work. We've gained those skills, and now we can kind of really evaluate. We've got those skills. We know it works. We know that the infrastructure can support it. We know that the barriers, both institutional and personal, that have kept us from really doing this are not entirely valid. Where are the areas where this really could be of benefit to people in a way that's worth sustaining when we're out of the pandemic situation? And I think about our rural populations as one area where there's just no way to provide these services at scale, because the cost of having this service available doesn't match the population needs, and so using the scale that we have in urban areas to meet the needs of the rural areas, I think one great example. One other thing that I would kind of touch on, since you brought up the Safe UT app, I think the Safe UT app is a great kind of a great, I don't know if metaphor is the right word, or it's a great example of something that came in that had this kind of some of these thoughts attached to, can this be an effective method of delivery? Who's it really for? What we saw in the process of creating that app was that there was a marked gap in terms of certain populations that just would not engage with a crisis service that was based on a phone call. And so that became the basis of really building out this app. So I think that with kind of our different populations that are really more technical natives, people that feel a lot of comfort in technical methods of delivery. For some of these people, this may be their preferred way of engaging with behavioral health care. And for that group, we know it works. We have the skills, and I think this is a great opportunity to take what we've learned and move it forward.
Thank you, Kevin. And just as you were talking, there was a question that had come up that I think I can answer. There was a question about CMS, and that's really the Center for Medicaid and Medicare Services. And those are federal drivers of whether something is actually, there's the conversation about what we think is going to be effective, and then the real, where the rubber meets the road is it valued enough that it's actually funded to use as a tool moving forward? I mean, that's really the question, and I think that's something that we really want to sort of talk through and really get actually not only the panelists' insights, but also those that are listening in as well. With that in mind, let's move on to Yuri.
Greetings, thanks for having me. So my name is Yuri Maricic. I'm the Chief Medical Officer at Payer Therapeutics. My background as internal medicine physician, practiced for a number of years, and have also worked in traditional drug or therapeutic development. And at Payer, we bring basically traditional therapy development and biotech approach and converge that with digital. So it's both the biology and the tech, or the putting them together. And what we do is we build prescription digital therapeutics. So these are pieces of software that are intended to actually treat disease. They're all based on scientifically valid mechanisms of action or evidence-based practices. We then run them through randomized clinical trials after they've been manufactured according to good manufacturing practices. So just way software like in an insulin pump or implantable defibrillator is coded. That's how we code our software. And then in randomized clinical trials, we evaluate them using the same endpoints, and then we take them to the FDA. And the FDA, if they agree with providing marketing authorization, will provide a label just like any other drug or medical device. And then the last part, and was alluded to here, that I think has a lot of parallels to what we're talking about with virtual medicine, is reimbursement through traditional third-party reimbursement mechanisms based on the medical value created, which, Tamara, you're just talking about. And maybe just a few comments on the models of care. I think I've been incredibly excited to see what have been primarily reimbursement, legal, and clinician licensing requirements really holding back telemedicine. And seeing that with COVID as a catalyst, that's really provided rocket fuel to meeting patients where they're at. And that has been a key challenge for healthcare, is providing that access, but access not just in terms of, is there a clinician or can you get paid, but can we actually reach you? And is it care delivered in a way that fits your needs? And unfortunately, we've tried to make patients adapt to us rather than us adapt to patients. And so I'm really excited about the models of care that we're going to see. This isn't just about cutting and pasting what was face-to-face care and now put it in front of a video. That's a huge step forward, by the way. That just there is a huge step forward. So I don't want to belittle that in any way. but moving from traditional face-to-face and brick and mortar paradigms to what I think a number of the panelists here have all mentioned, which is hybrid models of care, adapting different levels of care to different stages of where patients are at in their overall either an addiction recovery journey or disease treatment or episodes of care. And then also, I think was highlighted by several people, the difference between synchronous and asynchronous care. So there's definitely value in terms of synchronous care and having clinicians who can use our incredible skill and pattern recognition. But there's also, particularly in behavioral health, lots of repetition, lots of need for patients to get care and access to care after hours, not during 9 to 5, on the weekends, when they actually have need. And again, you know, Cliff was talking about this with addiction patients particularly. They don't have their urges and cravings or their exposures to need only during business hours. And so how can we all collectively, as clinicians, as decision makers, to really think about a lot of what telemedicine is enabling or virtual care is enabling, to rethink those models of care in a way where we really meet patients at, where we're then starting to get to the kinds of discussions I think we all want to have, which is around how do we do that but with quality? How do we do that but with value? What is the stuff that actually we see that return on investment in terms of either clinician time or dollars spent, while continuing to enable access? And this gets to, I think, the final point that Kevin brought up, which is we're essentially talking about reinventing then these paradigms of care. But it's in a way where now technology is really the tool, and it's just about delivering care. It might be online, it might be asynchronously. There's a whole new set of tools for us to rethink that.
Wonderful. Thank you, Yuri. Appreciate that. And it just a kind of a follow-up question, or maybe a question / comment is, you know, you mentioned something that really, that I really appreciated, which is the idea of not sort of imposing technology on the consumer and on the member, but rather, you know, what's the gap, and then what, you know, how can we best reach them? Do you mind sharing with us a little bit about how you think about that as an organization, as you're developing different tools to really try to determine where are those opportunities? You know, a lot of these I know are, you know, we start with sort of a theory in terms of what works and what doesn't, but I'm just curious about how you think about that in terms of meeting that client, patient, member need.
Yeah, sure. Happy to provide a couple thoughts. Maybe just as a framing comment, though, is I don't want anything I say to be interpreted as that I'm advocating for replacing clinicians with technology. So I think that's just as a backdrop, is we can't replace that. Technology is only good as the direction it is given by us as humans. Care is ultimately a human act. Healthcare is a team sport. Rather, it's how do we apply technology in a way to meet patients where they're at, as I said before. Maybe just a couple examples. I think one, and I think this was actually mentioned or alluded to earlier, is around phone calls. I'll tell you, patients, particularly who are suffering from addiction or other seriously mental illnesses, are not oftentimes willing to pick up the phone. They communicate via text. That's even how they get their substances. They don't know who's on the other side of that phone call. And so you have to find and adapt those ways of meeting that treatment. In terms of access, though, the ability to, whether virtually or through a digital therapeutic, to provide access in remote and underserved areas is really key. And I'll just give you one other example. So we've been working on a therapeutic for patients with schizophrenia. So just like in addiction, we have done work in chronic insomnia, but in schizophrenia, patients actually have this profound technophilia. They struggle to read and interpret nonverbal cues by many of us providers, but they love that predictability of software. They love actually playing video games, many of them. And so this is just different aspect of their disease. And so those repetitive aspects that many of us may find are not as fulfilling can, for a patient with suffering from schizophrenia, really be engaging. And I think we just see this across disease area, but the important thing is not to do it in a one-size-fits-all way. It is trying to understand different patient populations, different diseases, and then provide a wrapper of human as well as digital means to engage with them.
Thank you, Yuri. Appreciate that. That's really helpful. And I kind of thinking about those processes, and we're, you know, it's interesting. There was a question that was actually brought up along those lines, and it's a bit of a practical one as we're thinking of some of these strategies. And I suppose, you know, sometimes it's just as simple as how are we managing leveraging our clinical licenses when there are barriers just within the jurisdiction of the state, as an example. You know, there had been some loosening of some of those, depending on the state, in terms of the ability to treat someone in a different state. And how has, you know, how have we been able to overcome those challenges? Because we've kind of created some, I suppose, some barriers around that. What have been some strategies that people have utilized so that the treatment can truly be ubiquitous, given the fact that, particularly in behavioral health, there's a very limited supply in terms of the workforce, and the ability to sort of utilize those across the country can be challenging. Any thoughts about that? Throw that out to the group.
From our perspective with the Division of Substance Abuse and Mental Health, we've been doing a lot of work on capturing as much information as possible with all the calls that have been held, the reasons for the visits, how long the visits lasted, but then we're also trying to do some work in capturing the location of the provider and of the caller to show the cost savings as a result of the telehealth, but also to show that calls from different distances are equally effective. And so we've been trying to capture that information with the intent of presenting that to decision-making bodies to show that it doesn't matter, you know, if you're in different counties, different parts of the state, across state lines, the calls are effective and the treatment doesn't change. So that's kind of where we're starting. Once we have more information and more data to back up what we're trying to do, hopefully that'll push those conversations on a little further.
So really kind of
as a payer, that raises a significant concern for us because of coordinating care. You know, we have a large network of providers that care for our members, and you know, if a primary care physician caring for an individual is left out of the loop of care being provided in behavioral health, you know, we worry that the care won't be as effective. So I think it's entirely correct to think geography is probably not the issue. It's probably connectedness, and how connected somebody is to the system of care, how connected they are to the member, and how they maintain that connection. You know, I think we would all agree the last thing we want is a one-off contact that's effective in the context of that one-off encounter, but fails to bring that care into the treatment plan for the individual in a durable and effective way. And so, yeah, I think you know, this invites an opportunity to think about the coordination of care in new and different ways, and to recognize the importance of the coordination and let go of the concept of geography.
Yeah. I appreciate that pivot to really think about proof of concept. Sorry, Cliff, you're about to say something?
Yeah, I just wanted to offer a resource. I'm just going to send a link out to everybody. It's through the Person-Centered Tech. It's, you know, they have created a survey and have a whole listing of, you know, at least right now, the 50 state emergency kind of practice rules for all different, you know, provider types, which is a great resource for, you know, everybody that's participating in this webinar right now. And I think we've made, you know, 5 or 6 years ago, I mean, we didn't have, you know, GT or 9.5 modifiers to, you know, bill, you know, for, traditional in-office service codes. You really couldn't do anything, between states or across state lines. But we actually have made quite a bit of progress. I think there are still some challenges. For instance, I had during the COVID crisis, I had a patient that, we were treating here in Utah, and went to Texas to go visit her son that was living with her, ex-husband, and got stuck there, couldn't fly back, and was sitting there in a hotel room. And so, wasn't necessarily having a major emergency or crisis, but needed, a contact that she had an established relationship already with. She needed to be able to contact me and kind of, at least inform me where she's at and how things are going and what her mental health and mood state is and how her med management is going. And so the challenge there is Texas, right now doesn't, they don't, not even for the emergency, and a lot of other states do, but Texas didn't even for the emergency allow, provider client relationships across state lines, even if the patient was visiting there temporarily. So although we've made lots of progress, I think there's still some major challenges. But that's one thing that I, would really love to continue to work on, is this idea of, we're talking about telehealth, virtual therapy, we're talking about telepsychiatry, but there's this other piece that comes up for me, which is this kind of new concept of telejustice, kind of like social justice, right? And so I agree with, Dr. Whittle. I mean, it really ought not to be about geography. It ought to be about really patient care and patient safety with an established and trusted provider that they have, even if they're, in another state temporarily or permanently.
I appreciate that comment, Cliff and Dr. Whittle. I think, and others, to really think through, as Pete sort of talked about, kind of demonstrating the value, also recognizing the importance of potentially some of the risks of considering working across state lines without thinking about the coordination in and of itself. And then, really thinking about that from a practical perspective. What I can share, one of my other hats, I sit on the National Association for Social Workers, the Utah chapter, and we've done a lot of work and worked closely with Doppel about
Is it just Tamer, or have we all
Can
lost?
you guys hear me now?
Yeah, gotcha.
Great. Wonderful, wonderful. I had to change different devices because these batteries just went out. I've been on them too many times. What I think the piece I wanted to share just from a practical perspective is the realities are that to really advocate through your associations for actually each jurisdiction will dialogue with other states about creating these swaps so that they will accept them in your state while others accept them in others. And so there's a lot of work going on from an advocacy perspective, but it's not been from a federal perspective. It's actually been a state to state. And actually Utah has done some work to reach out to neighboring states. So it's not necessarily within the emergency per se. And so I think there may be some opportunity, given that there have been temporary loosening of those expectations, to really create opportunities to advocate for that. And so we have seen some of that work that's been going on for quite a while, but there's still a lot of work to go, as Cliff indicated. Kevin?
Yeah, so getting back to your earlier question about strategy and kind of tying it back to this conversation, when this hit, we didn't have time for strategy, right? We were just all kind of solving each problem as it came up, and it was interesting to watch as all of these dominoes fell of the things that traditionally made this not a workable solution. We saw payers agree to compensate for it. We saw states agree to relax their interstate kind of rules about what's allowed. And all of a sudden we were able to really focus on, okay, providing care. So my experience with the University of Utah was that they had some of these tools already built, and they were able to kind of roll them out pretty quickly, which was really great. And we had this kind of experimental design that kind of came together where over a short period of time, we've been able to really start collecting a lot of data about how we're using this, how it's working, all of that sort of stuff. So I feel really strong that the time for strategy is now, where we can take what we've learned from this outside of the context of all of these traditional barriers, and really kind of put together compelling cases for why these emergency measures aren't really something that was made necessary by COVID, but are something that should have happened years ago, and is something that we need to continue moving forward. The emergency was there before COVID. The emergency is that people were not having access to mental health care in an easily accessible way, in a way that kind of met their needs and was provided in a way that they were able to take advantage of. We have proven in the short period of time that this is something that belongs in the larger continuum of care. And so our strategy has to be around leveraging what we've learned and the data we've collected and the experience we've had to saying, this is not something that just meets the need of a pandemic crisis. This is something that meets the need of a larger mental health crisis.
Appreciate that. One of the questions, again, I really appreciate the audience and the attendees with kind of this sort of thought is like, so what do we do if they're, if the panelists are saying that this is valuable, and I'm hearing, Kevin really highlighted the importance of really making sure that we demonstrate that. What can a provider do to advocate to ensure that? I think back to Dr. Whittle's statement that geography isn't the issue we're trying to overcome. It's maintaining coordination regardless of where people are at. Any thoughts or ideas about how some of these attendees, some of these folks that are interested in sort of advocating for this, any thoughts about how they can help support this?
I'll jump into that. So, I think the solutions to that coordination have been challenging. There have been codes opened up that are supposed to reimburse for coordination of care, but I'll tell you that utilization of those codes is extraordinarily low, and the coordination of care, our belief is that has to be a technology-based solution, that people have to find and subscribe to the platforms that coordinate care, and that that coordination of care has to connect to the medical providers within a person's system of care, and they have to connect within the social determinants realm. I think they have to connect within, certainly behavioral health and substance use disorder treatment. And without technology, I think we all just have to acknowledge we're not going to accomplish that as if we live in small towns and we're going to meet for lunch. That's just not how this is going to happen. It has to be a technology-based solution. And I don't mean to be glib about that, but there are technology-based solutions to this. And I think providers have to seek those out and support them, because that's a marketplace. And I think those of us here who have administrative roles within systems don't generally participate in that marketplace. That marketplace is at a provider level, and I think is robust. Look at what happened with Zoom in the stock market based on this happening. I think it's a marketplace, and I think the marketplace has to decide that. And I think you're going to vote with your choices to provide care that, again, I think we've been consistent on this. It's not replacing face-to-face care with video-based care. It's changing how we do care and using platforms that allow for that coordination of care and make it easy. If it's easy, it'll be done. And that has to be the solution.
So I'm really hearing kind of the driver of some of these changes is really kind of the driver of the market and the demonstration of that value. That's certainly an important force. I think for many that are on the line. I mean, it's important to kind of align that kind of dialogue and have some organization about it. And I'd recommend going to your affiliate association to help develop that that alignment with what the need is based on the experiences that we've had over the last 3 months. And I think there's some opportunities to absolutely do that. So go ahead, Cliff.
I was going to say something. So, so like I think everybody agrees is, telehealth does not replace human presence and human contact. I mean, that's one of our, basic human needs. But I think, we can't have a future with the level of comprehensive and integrated care that we want when it comes to, all the televideo and telehealth stuff that we've been doing throughout the COVID pandemic unless we invest. I tell people all the time, a future has to be something that's invested in. And of course, this might be to a large degree, a marketplace issue. I think also it's, for one thing that we can do, each organization can, increase their budgets for their IT departments and their improved and new devices, and make sure that, the technology budget line item is near the top. And then I think also, like Yuri was saying, that the technology is only as good as the user. And so on top of having an increased IT budget, I think we also have to find ways to help clinicians and providers, move past, above and beyond their own kinds of setbacks. One of the greatest challenges and barriers that I've faced through this COVID pandemic is that a lot of providers, a lot of my colleagues and the students that I teach can't get past their own setbacks when it comes to technology. And so I think we have to invest not just organizationally, through budgets for IT departments, but we also have to invest in our staff to make sure that they are trained and equipped for the long term and in, new and improved ways with every new technology that comes out. I think that kind of investment will help as well.
Appreciate that, Cliff. Really understanding the importance of investing in the technology and investing. I don't even want to call it, I jot down training, but I think it's more of really thinking about a different way of delivering and stretching the provider's sort of comfort zones to really develop other skills to deliver on that care. One of the panelists sort of highlighted just kind of from our previous conversation, the fact that they're, they have licenses in 8 different states, and the logistics to do that is a significant barrier to have to maintain those sorts of things. And so they were pointing out that really this change needs really to come from a state and federal level, and that's really, really important. So I appreciate that insight.
Hey, Tamer, real quick. University of Utah Health about 4 years ago undertook a big project to try to figure out, could we create Intermountain West kind of focused telecrisis kind of service to try to help address some of the rural access needs. And it was exactly that issue that ended up being the final nail in the coffin that made it not happen, was just the administrative and financial cost of managing a group of providers to have licensures in the states that we were looking to go into. So, getting back to your question of what can we do, right? We know that the excuses for why we can't have more interstate cooperation on this are just not valid for the most part. We know that the technology barriers that had always been a problem are not valid, or not entirely valid, right? And so, like I think that there's a big place for collecting our outcomes from this. This experiment that was forced upon us all, right? Do we have outcome measures? Do we have anecdote? Do we have kind of what ways in which this helped us solve a problem that we couldn't have otherwise. Really, the barrier to telehealth historically has not been one of I'm trying to think through what I'm trying to communicate here. Telehealth isn't the intervention; it's the method of delivery. And there's been a lot of focus on telehealth as not being a valid method of delivery. So we really have to use this opportunity that we've been given to really prove the method of delivery is just one more tool. It can work if done correctly, and we need to use that to be able to go back and challenge these barriers are going to come back. There's a point at which we're no longer operating under pandemic conditions where payers are going to start saying, well, telehealth is not as good, so we're not going to cover it. And we're going to start seeing states back off of these interstate agreements to allow practice across state lines. And all of a sudden, we're going to find ourselves back in the same position where we're fighting the exact same old barriers. So we really need to leverage what we've been able to accomplish in this short period of time to really have an argument in advance of those things being pulled back to say, it would be criminal to allow that to happen.
And you've really hit on a point, and Scott, Dr. Wood, let me get you as well in the conversation. You hit an insight that I really appreciate. Oftentimes, at the provider level, the provider is just interested in having a connection with their patient, and perhaps that sort of approach is perhaps ill-advised versus. It's not so much connecting, but does it make a difference? Do we have the outcome measures to demonstrate that it actually has an impact? Do we have that infrastructure of outcomes into our own systems that we can actually demonstrate that beyond what the literature suggests, but within your own practice? Dr. Whittle?
Yeah, I think that's well said. And I generally support what you're saying, Kevin. I would agree. I would add to it that, I would try and explain how we're seeing the landscape. We're really paying attention to our members' experience with all of this. And by and large, we believe our members' experience has been very positive. And so from a patient member satisfaction perspective, I think we're winning the day here. I think it's going well. And so on one sense, the genie's kind of out of the bottle. We're not going to be able to put the genie back in the bottle. So the question is, what is it going to look like? Because this is a very effective delivery strategy. All of that resistance has really been pushed through, and we have a ton of data. So I think you're right, but member experience and people really liking this delivery is going to weigh in. And I think we have to collect that and understand it better. And I think the efficacy, where it works the best, has to be clarified. And Sean connected me to, some work that's going on in other areas that I think, Cliff, you mentioned earlier that tech is more than just care delivery around face-to-face. It's also apps and things like that. I think people have generally agreed. Yeah, how do you interlace these technologies to really improve the member-patient experience and really up that efficacy with, and this is the crux of really what I'd like to say is, all behavioral health is a limited resource. I can't fill my network and meet my members' needs. And so the real ask here is to deliver care more broadly, and it has that justice element to it because we're not reaching, behavioral health, and I apologize, I'm getting on a little bit of a soapbox here, but more than almost any other specialty, behavioral health is doing boutique care in many cases. We're treating the well, and we really have no business doing that, frankly. We really have to be pushing care out to the most ill, to the most, the rural folks who can't get into care. We really have an opportunity here. And so delivery out in a way that makes the state of Utah look isn't the right word, get the care they need. We have a real opportunity here. So I agree with you completely. We need to show efficacy, but I think if we keep our focus on the patient experience, I think that's going to guide us. I think that'll guide us to this because the people in the most need are going to shape how this response looks like downstream. I'm really excited about what we can do with this.
I really appreciate it. No, that's great.
I jumped on the soapbox.
No, I appreciate that perspective. Yuri, do you have a comment?
Yeah, I was just going to add, I mean, a lot of what you were just saying, Dr. Whittle, really resonated. And, you know, I saw many examples of patients with severe physical diseases, COPD, heart failure, diabetes, who they come as frequent flyers in and out of the emergency room, in and out of the hospital, and everyone is, you know, just falling over themselves to help treat their physical disease, and no one is bothering to coordinate or treat their bipolar or their schizophrenia or their addiction or their major depressive disorder. And so we're just throwing Band-Aids, you know, to your point. And this also means that we are not doing anything to help bring value. Right? These are some of the patients who contribute the most costs, and we're spending a lot of money, but we're not getting anything for our money because we're not actually focusing at a lot of the roots of the problem. And as I was listening to that, followed also by what you were saying, Cliff and Kevin, is I think in order for us to solve a lot of these problems, we do have to be focused on the experience. We have to interlace this. We have to show those outcomes to get to value, so we know what is an incremental unit of value per every either dollar of cost or minute of a clinician, et cetera. But it's going to really require leadership and collaboration. It's going to require leadership at the provider and the payer level or the health plan level, but it also requires that collaboration. Like, you know, you were mentioning, Dr. Whittle, about the fact that there's codes for coordination of care, but they might not be getting used that much because there's not that collaboration yet where providers are saying, gee, we need to invest in these systems. We also, to your point, Cliff, have to train them how to use them. And that requires internal champions at providers to champion for that. But then they also have to reach out to their counterparts at their health plan and say, how do we make sure that the time and the value gets compensated in a way where everyone wins with the patient in the middle?
And I would just add that the potential cost savings, if we do that, I mean, the spend on behavioral health, you know, substance use disorder, treatment of behavioral health conditions, the spend is a small fraction of what we spend for those medical issues that you were mentioning. And so the potential savings here, we believe, is in the range of, you know, 1 to 16, 1 to 22, somewhere in that range, if we get this right. And, you know, I would really underscore, and I think you all would agree, and the outcomes for the individual. The individual's life is better. Pretty much every time you reduce the cost of care by coordinating care and providing more consistent, better care, you bring the cost down. And I think we can have a big win here.
Yeah, I absolutely appreciate that. I was gonna, you know, it's interesting when we hear all this conversation about thinking a little bit more broadly about patient experience and thinking about the efficacy and really trying to frame things is kind of really a theme I'm really hearing about versus trying to bust a barrier. It's really about, you know, it's already happened. And so the question is how do we make that last? And so I really appreciate that context. We had an attendee sort of share a kind of a little bit of a flip of that thought in that the impact that they can have as a treatment provider, given their anxiety about treating a patient in person in this particular environment, and the opportunity for them to feel like they can still deliver care without the anxiety themselves as a provider, which I think is kind of an interesting point. And perhaps it's really about not only about the experience, but and also part of that experience is doing that in a way that's safe, and that people feel safe and comfortable. And when I say comfortable, I mean comfortable to actually do the work that's necessary in a behavioral health setting, and which is oftentimes challenging. I guess I'm curious. You know, we've only got a couple minutes left, and I wanna make sure. If we can jump in, and if anybody has any final thoughts about, brief thoughts about our conversation today before I wrap us up.
I'm just wondering if, I don't know if we allowed Pete an awful lot of time to talk. Is there anything else, Pete, that you had any input or, contribution to in terms of what we've been talking about? Any last thoughts from you?
Yeah, I think my last thoughts would be, as providers, you can be the biggest advocates. It's kind of easy at a higher level to get a lot of data, to get the numbers and present that, and to get that in front of the right people. But in a lot of cases, it's the stories that push things over the line when it comes down to decision-making bodies. And so I guess keep doing what you're doing, and make sure that you're sharing your successes with people in your networks, share them with your administrators. Those stories get passed on, and that helps people make well-informed decisions, which is going to be really important as we try to keep this going.
Sounds like another webinar.
Yeah, yeah, absolutely. Others? One of the things I just want to, first of all, I want to thank our panelists today and really share your insights and your perspectives about how we can think about really impacting, and I appreciate this, the conversation really pivoted about not so much about post-COVID and telehealth post-COVID, but really, it really focuses on is how do we enhance the members and the patient and the client's experience, and how do we do that well rather than just continuing to sort of jam the traditional mechanisms which we know cannot, particularly in behavioral health, will never meet the need in the current, given the current workforce and all of that. So I really, really appreciate your perspectives. I think that was incredibly insightful. And I also want to thank the attendees. Hopefully we were able to at least address or respond to some of the questions. It's been really, really helpful to kind of gain that experience, everything from sort of how to think about and kind of innovate, how to advocate for the benefits of this, and frankly, hearing it both, not just at a macro kind of level in terms of the efficacy, but also, as Pete highlighted wonderfully, the stories, and kind of Kevin's point about really addressing how do we make this accessible? And by accessible, we're not just talking about access and when the next appointment is, but how do we make it meaningfully accessible to folks? And so I really appreciate that. The asynchronous care, thinking about how truly apps can fold into that work, be thoughtful about those populations specifically. I really think thinking about that from a patient-centered perspective is really critical. Dr. Whittle, you're on mute.
You're on mute. Start over.
Sorry. I would just point you to Lana Dalton just asked a question about telehealth being used to go into jails, and I think it really points out opportunity here, because if you think about jails and places like jails that have had a very hard time staffing appropriate services, telehealth, a coordinated telehealth strategy is a beautiful opportunity. So instead of putting somebody physically in a jail, which has been incredibly hard, all you have to do is extend an existing system of care into the jail system to make sure that that individual never falls through a gap.
Right.
So we can essentially eliminate gaps with a coordinated system that just overlaps into settings like jails. Now, there's coverage issues there because in the system of Medicaid, there's some reasons why people fall in and out of care. But our view is players in Utah really should be working in all lines of business, including Medicare, Medicaid, unfunded, commercial, individual marketplace. So we can start eliminating all of those gaps.
Yeah, I think Lana's question is brilliant and really, hi Lana, I haven't seen you in a while. It really kind of gets at that concept that I kind of touched on earlier of telehealth as the intervention versus the method of delivery, right? And for people that are in and out of the criminal justice system, they don't get to benefit from in-person therapy because the most important part of therapy is the relationship with the clinician, right? And so telehealth becomes the conduit for maintaining the clinician relationship with somebody who cannot engage with it in the way that it's meant to traditionally address the patient's needs. I think that brilliantly kind of illustrates that concept of it as a conduit versus an intervention.
Right.
Wonderful. A wonderful way to close. We are completely out of time, and I just genuinely appreciate folks' feedback. We do have we have folks behind the scenes kind of pulling all the content that we may have missed, and so we intend to kind of loop back. But want to thank our panelists for your participation and sharing your perspectives and keeping this as a very, very rich conversation. So please enjoy the rest of your day, and thanks again for attending.